Hello, I'm Dr. Eric Castle here at Mayo Clinic in Arizona, and I'm going to be talking today about risk stratification for prostate cancer. There's been a change in prostate cancer over the years. When it was originally being diagnosed with a blood test, starting in the late 80s and early 90s, the cancer became very prevalent, meaning we saw it very frequently. And it was understandable because this was a cancer that was very lethal and scary to men. It's the second most common cause of cancer death in men in the United States, and the number one most diagnosed non-skin cancer here in the United States. So we can understand why there's concern with this cancer. But what's changed is the way we go about detecting it. There was a time 15, 20 years ago where every man, whether it was once or twice a year, was getting a blood test, that PSA or prostate specific antigen. And it was leading to some unnecessary testing, biopsies. And we came to the understanding that we didn't need to necessarily diagnose all the prostate cancers. And there were a lot of men, as many of you have heard, that would likely die from something else than their prostate cancer. So we've changed the way we recommend this. And there are some guidelines that we use, the National Comprehensive Cancer Network guidelines for the early detection of prostate cancer. And they give some insight as to how we should go about trying to detect that cancer. And the approach nowadays is that men should be getting screened or have that initial blood test earlier in life, and using that initial test, we then recommend how often they need to be screened. That era of getting it done multiple times a year or at various intervals, maybe even in public settings such as carnivals or fairs, has really gone by the wayside as far as what we recommend. That initial PSA test helps inform us as to what the risk for that patient is. And that's also sometimes when we use other tests such as genetic tests to help guide patients on how often they should be screened or if they should get a biopsy. And the reason for this, one may ask, is that these cancers, while still very common, aren't lethal in every patient. And furthermore, we're trying to preserve quality of life, because the treatment of prostate cancer, which will be covered elsewhere, can affect things such as urinary function and also sexual function. So we want to make sure that when we're treating patients today for prostate cancer, that they are at risk from this cancer as far as death or risk of it spreading, and make sure that we're not sacrificing too much to make that diagnosis. When we think about a cancer, we think about various factors when patients are diagnosed or even before they're diagnosed that help us determine how we're going to treat them, how we're going to manage them, and whether we need to be worried that the cancer is going to come back quickly or at a later date or never at all. And so we use a bunch of different variables or different pieces of information on the patient and on the cancer to make those decisions. So we'll kind of cover that today. We'll start with the blood test, which is the PSA. So patients who are being worked up for prostate cancer, they'll generally have a blood test. It's called prostate-specific antigen. That blood test is drawn in some patients for what we call screening, which is done less frequently nowadays or on very different schedules based on new recommendations. And we use that blood test to help us determine the risk of that patient potentially having prostate cancer. That blood test is also used in patients who have already been diagnosed with prostate cancer. We use that test when they've been diagnosed to help us understand what the likelihood that the cancer has spread or maybe is more advanced than we would have expected. There are some other things that we use once the patient has been diagnosed. So if a patient's already been biopsied, they've been diagnosed with that cancer, we then look at very specific things. So when we talk about a cancer, we talk about two big things that you'll hear: stage and grade. Stage is how advanced the cancer is. So a stage cancer that's very high would be a cancer that may have already spread to the lymph nodes or to other organs or has spread to surrounding tissues. Low stage cancers have not. Grade is basically thinking of it as how bad the cancer is or how nasty the cancer is, and that's generally based on how it looks under a microscope. So there are some cells that look very aggressive and they would be a higher grade, and there are some cells that don't look so aggressive and they'll be a lower grade. And when we're talking about prostate cancer, we have a very specific term. It's called Gleason Score or Gleason grading. When we hear about Gleason, it is the way we grade prostate cancer based on two numbers. So it starts off with a number 1 through 5. That would be the Gleason pattern. And we basically use that number to determine the two most predominant or most common cancers that we see in the prostate. And those two numbers are added together. And generally nowadays, we see Gleason scores 6 through 10. And the way we think of grades, or low grade, intermediate or middle grade, and high grade, we think of Gleason 6 as a low grade cancer. Gleason 7s are considered an intermediate grade cancer, so a cancer that probably needs treatment. And then high grade cancers are 8s, 9s, and 10s. And remember, those are combined scores. So a 6 is often 3 and 3. So that means that the predominant pattern in the prostate is a 3 in both the first area or the most common area, and then in the second area. And that's how it gets added up to 6. When we have Gleason 7s, you could have a 3 plus 4 or a 4 plus 3. Now in that case, the 4 plus 3 would be a little bit more aggressive because the predominant pattern is a Gleason 4. When we get up to 8s, 9s, and 10s, we tend to see the combination of scores being 4 plus 4, 4 plus 5, or even 5 plus 5. And that is the way we assess the grading of a cancer. By using that information and the stage of the cancer, we can then come up with a treatment plan. And that's how we risk stratify patients. And there are different risk stratification groups: favorable risk or low risk. There's even very low risk cancers. Those are patients who have very small amounts of Gleason 6 cancer, very low PSAs, and oftentimes those patients don't even require treatment. They'll be followed along throughout their life. But then there's intermediate cancers, and that's when we're starting to talk about treatments, whether it's surgery or radiation or some alternative therapy. And within the intermediate groups, we have a favorable intermediate, so that would be that 3 plus 4 we talked about. And then there's unfavorable intermediate, which would be 4 plus 3. The high-grade cancers will be the high-risk prostate cancer. And those are the kind of words that you'll hear when you're visiting with your physician, whether you're low risk or very low risk, intermediate risk, or high risk. And then after treatment is done, oftentimes surgery, where we can sample lymph nodes, the prostate's been removed. We then have very accurate grading because the whole prostate's been removed. And we have accurate staging because we've had CAT scans or bone scans or different studies that help us determine how advanced that cancer is. And using that information with your team that's taking care of you, whether it's the surgeon, the radiation oncologist, or the medical oncologist, we can come up with an appropriate treatment plan for you. So now I'm going to talk about the NCCN guidelines. There are a lot of patients that will sometimes get online and they'll have access to the guidelines that we use to help guide us in the treatment of patients. Now it's important to remember that these are guidelines. That means they're not absolute. And doctors use them to help make informed decisions for the patients, and the patients use them to help them determine if their treatment plans are falling in line with what they would expect. So in the National Comprehensive Cancer Network guidelines, we have different risk stratifications, very similar to what we had just talked about. And that's where they come from: very low risk, intermediate risk, and that is favorable and unfavorable, and high risk. And those are the way we come up with those guidelines on how we're going to treat patients. And that's in the treatment guidelines. There's also in the diagnosis guidelines where we use those risk stratifications to help determine how patients are going to pursue certain, not just treatments, but even just follow-up, whether it's surveillance or they're going to have additional imaging or x-rays or additional blood tests. You also see sometimes, not only in guidelines, but different scores that are assigned to patients. Some patients will talk about various scores such as Capra score, D'Amico score. There's even certain what we call nomograms, which are calculators that you can find on the internet. Some of them are through different cancer centers, and you can use them to help determine risk of the cancer coming back, risk of the cancer having spread already. And again, that helps inform the patients, inform you, inform us as your treatment team to help make decisions for you in the future. We also sometimes use some genetic testing. Now, I do caution patients because there's different genetic tests out there. There are various companies, or as we refer to them, vendors, that have various tests that are offered. They can be done in the setting before someone's been diagnosed with prostate cancer. They can be done in the setting after someone's had a biopsy to analyze the tissue and help make a determination on what the risk of having missed a cancer is. And they can even be done sometimes after there's been treatment, such as when the prostate's been removed. There are some genetic tests that are used, and those tests can help us determine whether people may need or are at risk of needing additional therapies. Sometimes it's radiation or even chemotherapies and hormonal therapies. But these genetic tests have to be taken very carefully as far as how we're going to be using them, how patients will use this information to make their decisions, because they're not as absolute as we think they are sometimes. Some examples of some of the ones we use are some that we use to help determine whether someone needs a biopsy. In that case, there's a particular test that's out there called the PROMPT score, which is a specific score that helps patients determine, based on their genes, what their risk factor of having prostate cancer or a high-risk prostate cancer, so that they can make a decision on whether to biopsy aggressively. There are other scores, one called Oncotype DX. There are additional scores such as Prolaris, and those are used often on the tissue or the cancer itself to help make decisions on how to follow patients or how to treat them. Again, I encourage you to discuss these with your physician very specifically, because it's very hard to determine sometimes how many tests to use, when to use them, and when the information is going to be useful in making a decision for you. So now that we've talked about the risk factors, there are some other things that we take into consideration to help determine treatment. Those could be age, other medical problems that patients have. So for example, if we have a patient who is 90 years old, and even though their family lives into their hundreds, that patient's very unlikely to die from their prostate cancer. So that factor will be taken into consideration along with the risk factors such as stage and grade. Additional factors such as health history, previous surgeries, heart history. There are some patients, for example, who have very complex medical conditions, including history of heart disease, lung disease, that wouldn't tolerate some of the treatments. And in those cases, we might recommend following the cancer. There are a lot of patients that will never die from prostate cancer and may not even need treatment. And therefore we use age and even family history. There are some patients who have a strong family history of prostate cancer where you'll see a group or a cluster, as we refer to it, where men in the family are dying from prostate cancer. In those cases, we might use that risk factor along with the stage and grade to recommend very aggressive treatment. So again, I would recommend that these factors be discussed with your physician so you can make a very well-informed and well-designed treatment plan for your prostate cancer diagnosis. But again, there's so much information available. These scores, these calculators, the genetic tests, the companies that are out there selling them, and it's very important to have very thorough, well-thought-out discussions with your physician to help make those decisions on how you reach your treatment plan for your prostate cancer diagnosis. Again, my name is Dr. Eric Castle. I'm professor of urology here at Mayo Clinic in Arizona with special expertise in urologic oncology or cancers of the urinary tract. Thank you for seeking out and accessing this information on this website. It's very important for patients to be armed and informed regarding their diagnosis and their disease process. We encourage you to look further on the website and access more information, and feel free to contact us at any time.